Great. So thank you everyone for coming. People are just coming into the room, and we're gonna give a little bit of a little moment for people to come into the room. I have some housekeeping announcements as well. Welcome, welcome everyone for joining us this morning, or whatever time it is, wherever you are. People will still be continuing to come in, but let me start with some housekeeping announcements. Um, Sweet 16, this is actually the 16th annual meeting for HARC, the Health Literacy Annual Research Conference. It's kind of astonishing that it's 16 years already. I'm certain that when I started this, I didn't have only gray hair, but it's still hard to keep track. The conference has been put on in association with IHA as a sponsor. And so if you're not familiar with IHA, please, you can go to the Solution Center or to the Health Literacy Academy and learn more through the IHA websites. It's also being done in coordination with the journal. I think that's the next slide, Health Literacy Research and Practice. And if people are familiar or not familiar, please check out HLRP. This is the research journal dedicated to health literacy that I edit. If people have questions about this, I'm happy to answer them. Another general announcement, please, there will be an email that comes to you for evaluations. It's actually super useful and helpful for us. We do aspire to get better each year, and we really loved your feedback. If you could please respond to those emails for evaluations, that would be just fantastic. Another general announcement is the posters. Posters are available for you to look at through the website. They're up already now. Unfortunately, as a virtual meeting, you don't have the same kind of interaction that you might have at a poster session with the presenter. But nonetheless, the emails for the authors are there on their posters, and they've all agreed to please reach out to them and send emails with questions or comments about those posters. That would be fantastic. Okay, with that, actually, I'd like to move on to today's business. Everyone, because it's a virtual meeting, it's really hard to know exactly how to do the networking that might happen in an in-person meeting. That we have to just figure out and just email people as you see fit and try to connect with them. But of course, at the same time, it's also nice to not have to travel too much all the time. So there in this session, unlike some of the sessions, because it's a keynote address, in this session, you can post into the chat and also into the Q&A, and we'll have time for questions and answers. But I will be facilitating that with Dr. Osborne as this goes on. In other sessions, the mics can be open and people will be able to talk directly, but unfortunately not during the keynotes. It just will end up being too many people all at once. So with that, let me just take the opportunity to introduce our keynote speaker. So Dr. Osborne is really one of the most prolific members of the whole health literacy world, the whole health literacy research world. His team has developed and implemented health literacy tools really in a very substantive way in many different areas of the world. And you know, it's hard to underestimate Dr. Osborne's impact with respect to the health literacy world. He really is the lead for health literacy with the WHO and numerous other government agencies and partners. I'm happy enough to be affiliated with one institution. Dr. Osborne has actually appointments in multiple places, 3 different countries, 4 different countries maybe, I don't know, but it's really quite impressive. I don't want to. I want to let you, Richard, to take this the way you wanted to derive this in towards into your work for health literacy. But I just want to give people a sense that really you have been one of the leading lights internationally, and it's really an honor to have you with us. And I'd like to turn it over to you. And I hope people will post questions, but if they don't, I have plenty of questions for you. The last time I think we sat together was in Australia, but if you're going to spend months at a time in France, I'm happy to come join you there as well. All right, be well. I'm going to turn it over to you.
Thank you, Michael. Well, really, I just like to do research and try to have impact and try to engage with lots of different people as much as I can and have fun. So what I want to do today is share you part of our journey and some of the innovations that we've generated. Now, hopefully I can share my slides appropriately. All right, I think this is working well. Okay. Indeed, I'd like to acknowledge my terrific team over the years, different teams and different institutions, but also my funders, the National Health and Medical Research Council in Australia, who provide fellowships and grants in different government agencies. And then in Europe with Santé Publique France, the premier public health agency in France, and I'll introduce some of that work later. I'm really happy to take questions at the end, and hopefully I'll provide useful information. I may annoy some people. I'm up for impacting as fast as I can on health equity, which may lead to perhaps jolting or perhaps suggesting that we can do things better. So moving on, why we need to be in health literacy. Well, actually, most intervention projects and research is not reproducible. I mean, that's actually really well known. This is from the biological sciences, but it's the same for public health. This is from Nature by Glenn Begley and co. We know that about 80% of research is not reproducible. We can't do it again, even the same laboratory. We don't get the same results. Why is this? Well, in public health, it's got something to do with, I think, poor intervention development science, poor conceptualization, and then also poor implementation. So today's presentation hopefully will show how health literacy thinking can support understanding of the mechanisms behind why people are being left behind. Our area of health literacy really is about reducing inequalities. Outline a strength-based approach and maybe how that's different to current approaches, and then also to enable effective use of authentic co-design to ensure you build needed, wanted, and equitable, and effective and scalable interventions, and that's some of our main business. And I'll just go through a few slides to show you actually how we got to where we are today. So for us, health literacy is a way to understand what are people's health information needs, why some people don't know what to do to look after their health. Health literacy can help understand why using medications and lifestyle change can be so difficult for some people, and why many of our interventions are so ineffective and exclude many people. And also health literacy is a way to understand what we need to do to improve service quality and effectiveness for all people, and much more, of course. In 2002, we completed and supported the WHO in headquarters in Geneva to produce this publication, Health Literacy Development for the Prevention and Control of Non-Communicable Diseases. It's 4 volumes. And this took effectively a 4-year global working group with global consultants and pairs of teams from different WHO regions, an immense amount of negotiation, and effectively 2.5 years of writing and negotiation to get this final document up with a huge range of the world's literature, but also many practical bottom-up ways of actually doing health literacy work. In here, we do have a definition. I'm not really very interested in definitions, but we do need to have them. But all the definitions tend to have something about accessing, understanding, appraising, remembering, and using information about health and healthcare for a purpose. The purpose we suggest is for the health and well-being of themselves and those around them. And then most definitions also have a context. And the context we put here in this definition, as viewed from a globally relevant perspective, this is people's knowledge, confidence, and comfort, which accumulate through daily activities and social interactions and across generations to do this work of accessing, understanding, appraising, remembering, and using health information. So that's hopefully that's kind of grounds you in the way in which we use health literacy, about this whole process of accessing, understanding, appraising, remembering, and using. So part of that journey from 2008 to 2013 was to come to build health literacy questionnaires and build our first manual to do Ophelia, Optimizing Health Literacy and Access, a process to co-design, build and implement interventions based on health literacy. The WHO in the Southeast Asia region commissioned us to do a health literacy toolkit for low and middle income countries, and that took an immense amount of thinking and effort to build that. And the WHO headquarters engaged us to build, as part of the global coordination mechanism for non-communicable diseases, National Health Literacy Demonstration Project initiative. This ended up being run in 6 projects in 11 countries. Then we got further grants, and at that time I set up a WHO Collaborating Centre, and then further fellowships supported us to push this even further. And then we produced the new version of the manual, which is online, which is easy to access, the WHO report and the demonstration projects. We began to see the health literacy questionnaire being taken up extremely widely. And then at the end of last year, the Joint Action on Cardiovascular Disease and Diabetes commissioned programs in 22 countries, and also further funding for us to really concentrate on globalizing health literacy for health and equity. So a little bit of thinking first in developing and implementing public health interventions. I put easy here in asterisks, scare marks, easy to fix problems in public health. Well, when the problem is really well known and well understood, it's perhaps easy to fix. And the causes are well known and can be stopped. We know how to stop them. And the intervention effects can be quick to see. So practitioners and community members and policymakers, when they see intervention put in place, it's obvious it can be fixed. And so that problem can be fixed. And when there's motivation from across sectors that are high to do an intervention, implement it, yeah, if it's high, we can have an impact. People who may benefit, it could be community through to government, are aligned. Everyone sees the benefit, feels the benefit, and there's all kinds of benefits that everyone can receive. And perhaps acute examples, this could be cholera and water, or diarrhea, smallpox. There's not really very many good examples in chronic disease because none of these conditions are really met. In chronic disease, we've got really very hard to fix problems in general. There can be very few obvious causes. Causes are unclear to the community. Causes develop over time, slowly, and come from nowhere for some people. Getting on cancer came from nowhere. My granddaddy smoked and for 80 years and he didn't get cancer. And the causes seem really unconnected to the effects, or hard to mitigate or stop. Interventions are hard to see. Interventions are hard to see. They're vague. They may or not happen over time. There ends up being very low motivation for policymakers and perhaps even clinicians and community organisations to try to fix these hard to fix problems, which are typically chronic conditions. And people who may benefit, well, it's unclear who they are. And it could be very mixed alignment or poor alignment with the needs of community through to government. And this really describes most chronic diseases. So our job to reduce inequalities with NCDs, non-communicable diseases, chronic diseases, it's really tough. And this is where 80% of the world's burden of disease is. So our job really is very difficult. And I think we can use health literacy to help accelerate our global impact for public health. So coming back to health literacy as we've conceptualized it with the WHO, 3 levels: health literacy of an individual, community health literacy, and health literacy responsiveness of the organizations. That would be approximately equivalent to health literate hospital concept. So they're all important. And of course, an individual certainly has to have some health literacy, or most individuals. But if they have a tremendous healthcare professional or professionals and terrific hospitals, terrific services, we can really overcome a lot of people's low health literacy by really giving them all the support they need. Even if they can't read, can't access, can't understand, we can support them with all these really well. And then community health literacy is terrifically important too. So the people around people, who's in the household, who's got great capability, who's in the village with great capability, who are the people looking after people in their community group, in their religious group. So we need to understand that community health literacy can be all-engrossing, extremely powerful too. So we can't really neglect any one of these if we want to have equity across the community. Then how can we use health literacy to build effective interventions? How can we really make this idea of health literacy useful for public health? So we've been looking at these 5 aspects of health literacy to allow, how do we can use them to allow people to effectively engage in healthy behaviour? Could be around, and so we've got a little statement, and this is just a very brief summary of much more extensive work in the WHO report. So with their accessing, people have different preferred learning styles. Not everyone learns the same. I'm dyslexic, actually, terribly dyslexic. So people have different learning styles and need to access different sorts of information at different times. Then there's with understanding, there's many levels of understanding health information, including no understanding to problem solving, from a person in a clinic saying, yeah, I understand enough not to feel embarrassed, perhaps, but do they understand enough to teach their child how to use insulin or how to eat better? So understanding is tremendously varied. And same with appraising. This is more than just believing or judging something as scientific or a source as trustworthy, but deciding if it's relevant or even possible to do. Appraising is hard work and really necessary and changes over time. Then retrieving and remembering, my goodness, there's a lot of knowledge that we want people to have for use in the future. In the future, we need to help people to know where this information is and how to get it at the right time. People aren't using that information we give them in the community health service or at that immediate time in the media or that immediate time in the clinic to use that information for their health. It's sometimes in the future. So we need to help people with that. And then for applying, whether to apply something is rarely a one-time decision, but a decision that people need to make repeatedly. So how to apply it, when to apply it, why to apply it, all this applying work is hugely different at different parts of the disease trajectory. And of course, many people have multiple chronic conditions, so it's tough work too. So we are asking a lot of our community members with their health literacy. So we need a well-considered mix of interventions to really have effective disease prevention and control. But how do people actually learn or absorb our wonderful messages? Well, there's 6 basic ways we think there is for people to actually learn: through printed materials, talking with health staff, through media, TV, radio, through community conversations with their friends, families, neighbours, religious or other community members, through internet and social media and apps, or through arts, songs, plays, paintings, and other kinds of formats as well. So all these are really key things. So if we think about our health literacy, we may begin to think we could develop a framework about the health literacy tasks and the way people learn. And that's what we've done here. Indeed, this is more detail in this. Well, I'm not going to go through all this. This is too much, just to give you a sense that if we can understand the well-being or learning pathway a person has and understand their preferred learning styles, we can potentially build very effective interventions or more effective interventions. Some of our partners are now actually doing a questionnaire based on these 6 levels of people in the community to find out which people in which community have this sort of learning style. So we may find that actually printed materials never worked, not for years. It never was very helpful for a particular community group. No one's asking for more printed materials. There could be other mechanisms at play to support people actually to learn and apply their health literacy issues. Now, this is really quite dense, but I have highlighted community health here. That is tremendously important. You may actually consider auditing your intervention to see of the tasks involved in achieving your outcomes, which of the particular health literacy elements are important for your particular intervention. Perhaps it was with elderly people, and you could do an audit and find that some of these ways of learning, some of these health literacy tasks are more important for people than others. This may be very interesting and useful for you to consider. Coming back to measurement of health literacy, us in the early days, some 15 years ago, we started doing some of this work, and we used the currently available health literacy questionnaires back then. And just very the realm, the reading, the realm and the TOEFL and the NVS, and we found tremendously different health literacy levels using these 3 different tools. As we came from a strong public health and epidemiology background, we found this a little bit troubling. And then also we had a national survey based on the NAL suggesting that 60% of Australians had low health literacy. But what low really meant didn't seem to have any scientific basis, at least in Australia. It certainly did with the TOEFL back then when it was built, because that was based on national data from a particular reference point now 15 or 20 years old. So the cutoffs are really problematic for us back then to actually guide us to either evaluate, let alone plan for intervention development. So thinking about intervention development, health literacy measurement to inform what we really want to do on Monday morning to impact on people's lives. So what we're able to do is build a health literacy questionnaire from the ground up. So what we didn't do was consult the literature, because we really wanted to find out what's going on in the hearts and minds of people in the community. So we asked this very general question, thinking about your experiences and trying to look after your health, or that of your family. What does a person need to be able to get and use all the information they need? Then we used a ground approach, concept mapping, brainstorming, sorting, multivariate analysis, a very dynamic workshop which put the researchers, registers in a corner and really allowed the community members to come up with what were their ideas and for them to group them in what they saw fit. And this is how we developed the health literacy questionnaire. We were looking to develop a short questionnaire, but we were told 9 very different things were needed to actually fully express this broad concept here that we did derive in general from the WHO definition from 10 years earlier. So the dimensions in the HLQ, the health literacy questionnaire, include feeling understood and supported by healthcare providers, having sufficient information to manage my health. And you'll notice that these questions or these constructs, each of these has 4 to 6 items in it. You'll notice they're reflecting a person's skill, or they might be reflecting practitioners' skills or competencies, or perhaps even reflecting on the organisation. So feeling understood and supported by healthcare providers, having sufficient information to manage my health, actively managing my health, social support for health, appraisal of health information, ability to actively engage with healthcare providers, navigating the healthcare system, ability to find good health information, and understand health information well enough to know what to do. And this was the main scale that had been used previously in many parts of the world. But we found 8 other things really quite different and equally as important as each of these. So since then, this graph's a bit out of date. We haven't done any update of this in the last year. We've issued more than 100 licenses since this was made. So it's been very widely used and taken up in settings that we had never anticipated. Well, I'd like to bring you to attention that people can have very different sets of strengths and weaknesses across the scales. the items and the concepts are written so that we could then take action in support of people with these particular sets of challenges. Indeed, if a person is tremendously strong on their social support, they can compensate for many other elements within their health literacy portfolio. So when we came to do the structural equation or the psychometric testing, it's been tested in many languages, translated to nearly 40 languages now, I think. And the psychometrics have been consistently very strong in Europe and in Africa and Asia. I don't have a lot of these up here, but you can see in Arabic here, in Twi, in an African language, it's very strong. We've actually been working to a certain degree with the FDA and other global agencies for measurement about really how to improve the concept of measurement and the concept of validity so that we are very responsible when we get a score. What does it really mean and the consequences of testing? Okay, we then, of course, built an e-health literacy questionnaire from demand and partnered with Copenhagen University to do so, using the same sort of process, ground process, getting the hearts and minds of individuals on their page, and then them co-designing this. So there was 3 groups of ideas here. The user's capability, ability to process information, engagement in own health, and ability to actively engage with digital services. Then also access to digital services at work and digital services that suit individual needs, really getting information about experience of digital services. Then the last one, trust and motivation, feel safe and in control. And 5, motivated to engage with digital services. And many groups are using either all of the HLQ and some of the HLQ and vice versa. So these 2 questionnaires blend very well to see the full picture of people's capabilities. And indeed, we see very different patterns of health literacy here too. Okay, how do we use health literacy data to develop effective interventions? That's what we're really interested in. Now, many of you, I'm sure, will have your favorite behavior change theory. And some of you follow 1 or 2 or 3, or some of you may never actually ever studied these, but many groups have their preferred model, which are important. They're all important. They all explain in the statistical models a certain proportion of behavior change, but they are relevant for different conditions, different periods of time. And not one is right. They're all explaining different parts of us fellow human beings out there. But what we're going to be very careful is to think that we've got to understand how much of something a person has and what they need. Both these 2 boxes here is representing how much a person has and how much they need of this to make a change. And when they've got the same amount or they've got more knowledge than they need, there's a chance of making behavior change. But that's not always the case. They may have lack of knowledge. They may need this amount of knowledge, they've only got this. So if they've got less, you're not going to get much behavior change. But this can go for much more than just knowledge. But we'll have knowledge gaps, we get no behavior change. Now, we need to consider all the different things a person might have. And here's just an example of 5 different things from the health promotion field, which might be important. But here, perhaps people have a strength, lots of confidence, lots of problem solving, but they may not have enough knowledge, or actually it's the environmental stimuli is important. So they can have strengths, they can have challenges, and perhaps there's areas which aren't that important or we shouldn't focus on. So we need to consider, what do we really need to focus on and build and support people to have the best chance of behavior change given all the potential determinants. And we believe and we develop the HLQ and EHLQ to be key elements that determine a person's chance of engaging effectively in health in their own care. And this is the biggest part of Ophelia, the Optimising Health Literacy and Access process, a way in which we go about co-designing health literacy. And there's an early paper which describes the rationale. I won't go into that too much detail. But basically, it's like any well-rounded program management kind of concept. It's got 3 phases: identify strengths, needs, and action areas, identify strengths is really important. We need to identify the strengths already out there, the strengths of individuals, the strengths of organizations. We have to identify really what's already good out there so we can take a strength-based approach. Then select, plan and test health literacy actions, and then implement, evaluate, number 3, and improve health literacy actions. But some of the what we do, it's based here at step 3 after the project sub, after administering something like the HLQ, the health literacy questionnaire. We build vignettes from those data, evidence-based data, to really represent the strengths and challenges people have, really to tap into their hearts and minds. So indeed, I've mentioned people can have different patterns of strengths and weaknesses, and I'll give you a couple of quick examples of how we've done Ophelia. So this one is from Egypt, and this is published in PLOS One if you're interested in, as a case study in the WHO report. So very quickly, 436 people took part in this process to co-design with fishing villages in Egypt. Women were specifically engaged through community nurses at the primary care centres serving fishing communities. So it was both men and women and whole community engagement. So we do understand that every particular individual in the world is different. So we take this very seriously with Ophelia. And what we actually do is cluster analysis. So it's an old-fashioned technique where we apply the questionnaire. We then do cluster analysis, which is an old-fashioned statistical technique, really, which finds 2 people exactly the same scores on all 9 dimensions and puts them in a group. Basically, cluster analysis works through the whole data set to put everyone in reasonably coherent groups of different patterns of strengths or weaknesses. So here you can see definitely a single health literacy score or averages wouldn't tell us very much about this population on how to serve them, how to build interventions. So in fact, we've got A to G, different subgroups of people in a community, and from this informs us of how to develop interventions. So different people have different things they're good at, different things they like, and different problems in getting and using information they need. So very quickly, this was developed in Arabic, and here is a vignette. Again, I'll go into detail here, but the health literacy questionnaire work was done here to build very specific vignette to I've actually coloured here the parts of this little story which coincide with the colours here in this vignette. Each of these is a score on a health literacy questionnaire, and you can see the 9 dimensions at the top. And so I've just done a vignette here for cluster D. So it really provides the mechanism inside a person's world, where we then can members or practitioners separately. Do you recognise this person in your community? And then we have a discussion about their issues. Then what strategies can we use to help this particular individual? We'll ask that question, get everyone's ideas. Then we'll ask, if there are lots of people like this in your community, what could community services and organisations do to improve outcomes for these people? In this way, we get hundreds of ideas on the micro individual level and on the macro organisational level as well. And these can be organised in various formats to really then build the fabric of a whole of community co-designed set of interventions. And that was implemented in Northern Egypt. Very quickly, another example in Australia now of using Ophelia to improve breast cancer screening amongst Aboriginal, Arabic-speaking, Italian-speaking women. So again, a large number of people took part. We were able to get lots of community engagement, and we did lots of workshops to get those ideas I mentioned before. Here's just another example of a vignette, and you can see here a bit more simply expressed. So just to help another way of understanding the importance of this, if any of you have ever developed software, the software company might develop personas, small stories of the typical users. Here we produce typical users, but based on evidence from the community, and then we go into detail what really is going on for people like that with best frontline practitioners, and also the people who live this every day, who have been successful and unsuccessful, who tried and tried, who've seen their uncle or aunt, the children or other people successfully manage their lives, and we get tremendous innovation from all this. Again, we ask these questions of how can we help individuals and groups to come up with hundreds of ideas. For this particular one, we're actually able to build 7 particular interventions. with the state-based breast cancer screening agency. One didn't work at all. We kind of knew that because sending out invitations in a person's own language, they may be illiterate in their own language as well. We sort of knew from the literature that wasn't going to work, but the agencies decided they really want to try this. Now, I'll just introduce you to two other ones. So one, actually ringing people in their own language, so Arabic and Italian. This increased people ringing up to book and taking part from 5% to 55% in the Arabic group, and then from 7% to 71% in the Italian group. So this is a 10 times increase with a no-cost intervention just by ringing people in their own language, often flipping back to English, but that was fine. It simply led to much greater attendance. We have this published also in PLOS One. Okay, with the Aboriginal group, women said, we don't feel culturally safe. We want to design our own shawl in our own colours and our own traditional design. And this led to an enormous uptake right across the state. And actually, this program now has reduced under-screening very clearly across all groups across the country, across the state in Australia. And it's going across to other areas as well. It's so owned by the community. In the documentary done by the Aboriginal community, you don't see my name, my university's name. It's so owned and loved by them. They're so proud of the work they've done. All we did was start the conversation using the principles of Ophelia. So, authentic co-design, really important. Strongly encourage you to think about these sort of issues. So I just want to quickly show you what we've been doing here with Jakarta. Well, I guess the uptake of Ophelia in different parts of the world. We had the WHO demonstration projects initially, a whole lot more programs started. Now there's a whole lot of new ones starting. And now with Jakarta, which is 24 projects across Europe being undertaken. We have a whole lot of examples of doing this work in very, very different settings. And then also much more recently, we have this work done here. All kinds of areas like HPV vaccination in Morocco, National Diabetes Services in Brunei, I'm not very carefully, minority groups and refugees in several countries doing this sort of work. We have an enormous program across all the prisons in New South Wales, where we have done co-design with prisoners, with health staff in the prison, and with the correction staff as well. We had a massive workshop last month where senior and junior staff came together to design how to be absolutely much better, much more efficient, much more equitable, and leaving no one behind in the prison system as well. Through two very specific ones like medication use and improvement in gout, a big project in Denmark. Now in Jakarta, the joint action on cardiovascular disease and diabetes, co-funded by the European Union. This is an enormous program, and our technical work package is one of 6 technical work packages focusing on health literacy. So overall, there's 142 projects across Europe in 18 countries. Really doing huge co-design is a huge part of this, and equity is a huge part of the whole program. So we have 24 projects in 11 countries, and we really had a massive meeting for most of last week in Paris. All these countries came to Paris, and we had a big program of really getting up to date, working out really what is working and not working, and working out much better ways. And we are so proud after the first year of the tremendous co-design, the community engagement, extraordinary. It is in diabetes, it's going from the prevention to control. Can't go into all these in details, but it's just tremendous variation. So as you're gathering, we use health literacy really to help understand interventions. So just often we do a project, we apply for funding, we start, we get the money, we start, we have meetings, and then we run the project until the end date, or us or our team move on to other projects in the meantime, and we submit a report. And outcomes, well, there's not a lot of accountability for outcomes. We do a report, but actually did anyone's lives change in the area of prevention or management? Any impacts? Often not even considered. So what we try to do in Jakarta is start really clear and modestly, very specific, and do tremendous amount of stakeholder and goal engagement to start, building community ownership in the intervention, really understanding health literacy, building on strengths, getting engagement and increasing engagement throughout the project, increasing ownership, and increasing reach, potentially not just within the one state you're working on, but other states saying, wow, that's a good idea, let's implement that. And you'll probably see an example from Christine Borja coming up in the next session. So then we'll submit a report, really trying to understand from day one, what are going to be our outcomes? What are going to be our impacts? So that's a tremendously important part of our work to start here, thinking about sustainability, thinking about scaling up. And this is what we're doing across Jakarta. So what's happening is we may also have some projects which start very ambitious, but they just don't go anywhere and finish. That may happen. But across all of our work in Jakarta with our 24 projects, we expect to have really very large impacts. So we're using what we think is world's best practice in health literacy development techniques, world's best practice in intervention design. So we actually have real impacts across Europe so that we can then understand, well, of all these 24 projects, which should be implemented across Europe, because we see common outcomes, see very careful processes that are doable across many contexts, or which should be just developed in a particular area. So it's very, very exciting. We're at the end of 1 year. We've got 3 years to go. That's going to be a very important, exciting program for us. Okay. Yeah, okay, I'll cover that already. So yeah, this is the Ophelia process. I'll cover this in a few examples there. I showed you this early on. We've got these easy to fix problems, but mostly in NCDs and health equity, working with hard to fix problems. We see health literacy as critical if we want to impact on diseases with complex causes and complex solutions. Often many sets of mechanisms can cause intended outcomes. Mechanisms can vary by context over time. Many mechanisms need to be working together to fix complex solutions. So in using the Ophelia process with a co-design with the workshops to get the hearts and minds of our best practitioners and community members to work out what's really working for them already or could work, we don't reproduce perhaps the literature which never really worked very well in the first place, and we get what is potentially or really is working in communities now. So thank you. That's where I'd like to finish just for today. Happy to take some questions.
Excellent. Thank you so much, Richard. I have a few things I wanted to bring up. Maybe we could discuss. And there is a posted question here, but maybe just to start, one of the things that I've always been impressed with your work, Richard, is the level of community engagement and the dedication in this space. And I mean, it's a lot of effort. It's a lot of time. But of course, you know, it's worth it if it works. But I have the following question, and I suspect you have lots of thoughts about it. Maybe if you have an example of where it works or doesn't work, and that has to do with lumping versus splitting. You know, the word community, it's very complicated how to apply it. And there'd be some scenarios where you say, really, this is work we have to do separately, this group and this group, or this community. And there's other scenarios where you say, no, everyone's in the same room together, and all kinds of variations in that respect. So do you have thoughts about this business, about, you know, when is lumping important, when is splitting important, and how this influences your thinking about the process?
Oh, terrific question. Thank you. Not easy to answer. When developing the WHO report, we had to work with what's called the best buys. There's the most evidence-based, strongest evidence for really impacting on NCDs across the world. There is evidence for that. And there's big policy initiatives, big pushes to do that. And I once gave a presentation with Dean Jamison, who actually compiled the world's literature in this from, I think, got to get the right institution correct, Stanford, Emeritus Professor. But by definition, the one-size-fits-all approach, the lumping, leads to leaving people behind. It's good for some easy things. It's good for those top-level things. We absolutely have to deal with misinformation, and many organizations like the CDC during COVID and WHO during COVID just put out so much information about this is the right thing to do, this is the right thing to do, this is the right thing to do. We have to do it in times of crisis for acute, well-known mechanisms. But everyone is special. Every group is special. They need to be treated special. And if really to scale up impacts, we have to have different parts of the community really owning their part of the intervention, investing their time, their energy. Groups are doing this in very potentially splintered minority groups. There's a terrific team in Portugal doing this, and they've engaged about 10 different migrant groups. And what actually happened is the migrants said, oh, we can do these co-design workshops. And they ran the workshops. We thought that the migrant groups wouldn't really even participate in filling a survey. But news got around that, wow, this is getting our voice. They thought they might get 200 questionnaires. They've got 1,200 questionnaires. And the community are co-designing their own solutions at scale. So lumping only goes so far, and you can't really tap into many mechanisms, and it will absolutely leave people behind. So let's just really work wherever we can within the communities being left behind and start from there, and concentrate on owned, loved, needed, wanted, implementable interventions, developing those. Therefore, we're going to be not wasting taxpayers' money as much and actually implementing something useful.
Yeah. Well, I have more questions about this, but maybe there's a posted question though, and it has to do with, how to manage the scenario if the community priorities are not aligned with the original, grant funding or the agenda of the funders.
Yeah, this is a really tricky problem. So when you do authentic co-design, the policymakers don't know what they're purchasing.
Right.
Policymakers want to purchase a particular product and have the KPIs, the key performance indicators, and all that sorted. So fortunately, there's tremendous range of examples of doing authentic co-design leading to big impacts. So certainly, as we now see in Europe, we've got many, many millions of dollars put in towards co-design. In fact, the European Commission has pushed, we shan't just implement what we've done before because we're not having much effect. We've got to do co-design and get community ownership, community buy-in, and that will generate more efficient programs. So often there isn't alignment, but that's where you really go to further work to have the stakeholders as part of your co-design team. The more we give energy, the more we give power, responsibility, authority, ownership to these other groups within the communities who may not be aligned with your initial particular intervention you're looking at, but we're all heading towards better health outcomes and better equity outcomes. That's the key principle we have to work from. So it's going to change. It has to change because we waste effectively billions of dollars across the world every year on interventions that aren't needed, aren't implementable, aren't wanted.
Yeah. Totally different type of question, if it's okay. About the HLQ, you mentioned I think a reasonable critique of some of the tools, like the difference between the Realm and the TOEFL and then NVS, and NVS is a harder test, and so the cutoff is different, but effectively, there is something of a cutoff that you're using and you're thinking about HLQ. You have different colors. You have red and green, and there must be some cutoff thinking. So what drives that the different groupings that when you're thinking about cutoffs for the HLQ, or did I misunderstand what you were presenting about that?
Yeah, there's no cutoff. So every data set is different. So there's no cutoffs. And those different subgroups come from the data. It comes from the patterns of strengths or weaknesses that are naturally existing in that particular community. And the colours are just relatively are just an expressions of highs and lows, so you can just see the patterns more clearly. And we never say a particular group's got high or low, because that's not particularly useful. We can have people with high health literacy on many levels, but then will refuse to take antibiotics even though they've got a raging leg infection. So no, cutoffs are really very problematic with any of the tools, except where there's been an evidence-based process to link a particular level to number of admissions or some national database of education, which is what was originally done with the TOEFL, which was the right thing to do because it was useful back then. But now we have many more dimensions which we can't get that sort of level of cutoff. So just using the response options is not a very scientific way of doing it to make a particular cutoff of high and low. And we don't see, I don't know, thousands of people lining up across countries because there's 60% low health literacy, according to a scale. We don't see massive problems like that. So there's a problem with the whole concept of cutoffs in many fields, actually, not just health literacy.
Right, but the concept of making the phenotypes implies that there's some way of categorizing within a dimension higher and lower. No?
No, you can see some people with high levels and low levels, depending on their world.
Well,
and
but within each dimension, right? So you have some way to making these patterns, right?
The patterns come from cluster analysis, where just two people with exactly the same score get put in a group of all 9 scales at once. And then is there anyone else with exactly the same scores on all 9 scores, and puts them in that group as well. So it's actually very far from the concept of a cutoff, and it's actually the natural patterns of strengths and weaknesses a group will have. And therefore, when we take these patterns to clinicians like yourself, say, hey, you recognize this person? Oh, yeah, they say all the time. I see people like that. And so then they can see clinically, well, when a person comes in to see you and many of our colleagues online, you don't treat anyone as an individual, as a clinician. You treat them as an average person. You have to treat them as an individual, thinking all about their worlds, getting as much data as you can, so you can make a particular recommendation about how they can make their world work for themselves. You're not sifting through in your repertoire in your mind, has this person got enough of this or enough of that? You're trying to see a pattern of the strengths and challenges clinic. So it's actually representing the tacit knowledge of clinicians in the community.
In the beginning, this is a very totally different zone. And in the beginning, you were talking when describing the WHO work. I think you used the word negotiation. That there was a fair amount of negotiation. This, people who are not used to the WHO at all might find that odd or unclear what that means. How does that play out, or how did that play out?
I was commissioned to be the facilitator of this global working group for health literacy and health education. And so it was my job to listen to all of the 6 regions of the world, each with 2 representatives, and make sure everyone's perspective was kept on the table. And so what came out of that was seeing that, well, actually 7 of the 8 billion people in the world come from communal societies. Therefore, individual health literacy doesn't really make much sense, because most people in the world don't make decisions like that. Okay, we better include that in a report, even though it wasn't how our colleagues from the West saw health literacy, but 7 of 8 billion people, they see it differently. Negotiation, goodness me, even the particular words, even particular nuances, even particular graphs, everything was, it's very risk averse, but it's normative. It's designed to really support member states, countries, to do the best they possibly can. So the negotiation was based on trying to get absolutely world's best evidence on the table, and to be actually fair to the experts and the regional representatives, and then going back to countries after the draft report for them to then have their input across the 4 volumes, for them to feel very comfortable. Yes, I will put my name on this. So, cause a lot of grey hair, as you were talking about earlier.
Yeah, I believe it. Maybe a very and totally easier thing. The idea of communities owning the work is really quite it has a really very important direction to go in. You did show a picture of the shawl project, but I didn't quite understand what they were. So how did they
Sorry.
connect the shawls to? Was it a cancer screening program, or what was the?
Yeah, I ran through that very quickly. Apologies for that. So
That's fine. That's fine. But yeah.
Yeah, it's really absolutely incredible. So, Aboriginal women, in their traditional way of talking in a yarning circle, they were talking, yarning, and said, look, we don't get screened because we don't feel culturally safe. We go into these white fellas places and we don't go. If we went and we covered ourselves in something we made in our own colours, the shawl covered them when screening for breast cancer. And the women came together to co-design the shawl and work together and produce them. So they came together as a community, then as a whole community, they went to get screened. And not just screening for breast cancer, but actually to get health promotion information about many other things. So it's been incredibly transformative from a simple idea into a statewide program going across the country. It was so amazing. The laser lights at the Melbourne Midnight Summer Festival, their shawls were projected across hundreds of Melbourne's buildings. And they love it. They own it. It's theirs. And therefore, had I tried to keep pushing, had I ever tried to push that this is got to put my university names on there, it wouldn't have got off the ground, would have nothing.
Yeah. That's awesome. So, so are people making them, or they're produced and then people buy them, or like, how does it work?
I believe the community are getting small community grants, and they come together and they make a dozen or so, and then they're treasured, and they then work with the mainstream health services. When the mobile bus comes across the country, they all turn up with their shawls to put around them when they get screened with their sisters. Beautiful.
Yeah. Okay. Sounds fantastic. Well, thank you very much for presenting today. Your work is very provocative in a way. From my perspective, is very provocative in just how much effort goes into the development side of things, and the idea of using measurement to drive design, to drive intervention design, is also kind of a key feature of your approach that I think that people can learn a lot from. And this kind of the basis of Ophelia. I hope people got an introduction to that. There's multiple papers written about this, and you just you threw out a few of those things. There will be a recording of this available to people, and you're getting some comments now about your presentation. There will be a recording of this, and so people can follow up, but also can easily find Richard's work published in all over the place. If there's any trouble finding anything, I'm happy to hear and help people find stuff. Probably Richard could do that as well. Peace to you, Richard, and keep up the good work. Stamina for the long haul that it's been and will continue to be.
Thank you, Michael. You're doing an incredible leadership job yourself, so I really appreciate the work you're doing. Thank you.
All right, be well, everybody. We're breaking up now into other rooms, and I'll see some of you over in one room, but you may go to another room. All the best for everybody. Bye-bye.